I am now pleased to introduce our first speaker, Dr. Christina Mickes, a medical officer on the Opioid Overdose Health Systems team in the Division of Unintentional Injury Prevention at the Centers for Disease Control and Prevention. She joins us today to share CDC's efforts to prevent opioid misuse and overdose. Christina?
Thank you. Good afternoon, everyone, or good morning, depending on where you're calling in from. It's a pleasure to be here today, and I appreciate having the opportunity to speak to you about this important topic. The United States, as we know, is in the midst of an opioid epidemic, which was driven initially by the overprescribing of opioid pain relievers in the treatment of chronic pain. However, more recently, we've seen a sharp rise in heroin-related and now fentanyl-related overdose deaths in a new but not entirely unrelated development in an epidemic that's really touching every corner of the country. I'm going to spend a few minutes outlining in detail the data underscoring the public health burden, and then I will spend a few minutes discussing CDC's public health approach to prevention, specifically highlighting a few of our signature initiatives. Overall, drug overdose death rates have never been higher, and we know that over 6 out of 10 of these deaths involve opioids. Through 2015, almost 310,000 people died from overdose involving opioids, prescription or illicit, in the United States. There were a number of factors that led to the current epidemic. To name a few of them, there was a history of pain being designated as the fifth vital sign, an underappreciation of the addictive potential of prescription opioids, aggressive marketing of these drugs to clinicians, just to name a few of these factors. This is one epidemic, but there really are 3 waves of it. And we like to think of the prescription opioid epidemic as priming the pump for the subsequent waves in some ways. And so that the rise in heroin illicit fentanyl-related deaths also have distinct features too. The first wave of the epidemic was prescription opioids, and the toll from this is still high. Through 2015, over 183,000 people died from overdose involving prescription opioids in the U.S. In 2015, we lost over 40 Americans every day to prescription opioids. Deaths related to natural and semi-synthetic opioids, which is the grouping that includes the most commonly prescribed opioids, oxycodone and hydrocodone. That's represented by the purple line on this graph. That increased 4-fold between 1999 and 2011. Prescription opioids continue to be involved in many overdose deaths. The death rate due to methadone increased 6-fold in just 8 years between 1999 and 2007. It's decreased substantially since then. That's the good news. But methadone is still involved in a lot of deaths relative to the amount that it's prescribed for chronic pain. So to put some numbers to that, in 2014, methadone accounted for 1% of prescriptions for pain relievers, but was involved in 23% of opioid-related deaths. I want to spend a few minutes focusing on the prescription opioid piece, since it really is what sounded the alarm for this epidemic. We know that chronic pain is common and that treatment can be challenging for healthcare providers. We define chronic pain as pain that typically lasts more than 3 months or past the time of normal tissue healing. Recently, data analysis showed that there's an estimated prevalence of daily pain of around 11% of the adult population. And to put that number into perspective, that's more than the 9% of Americans diagnosed with diabetes and about the same number as Americans with diagnosed heart disease. We also know that opioids have been frequently prescribed for this pain. An estimated 20% of patients presenting to physician offices with non-cancer pain symptoms or pain-related diagnoses, including both acute and chronic pain, receive an opioid prescription. And that's notable because primary care providers have reported concern about opioid pain medication misuse. They find managing patients with chronic pain stressful. They have expressed concern about patient addiction and report insufficient training in prescribing opioids. I've listed a few common prescription opioid pain relievers here. So that includes hydrocodone, oxycodone, oxymorphone, fentanyl, and methadone. Who's at risk for overdose? We know that as the dose goes up, the risk also goes up, both when opioids are taken for acute and chronic pain. Following a case cohort design and using a large data sample from the Veterans Health Administration, this research group showed that among patients receiving opioid prescriptions for pain, higher opioid doses were associated with increased risk of opioid overdose death. For those patients on a maximum prescribed daily dose above 100 morphine milligram equivalents, or MME, there was a 7-fold increase in death. And even for those patients in the lower range of 50 to 100 MME, the risk was still almost 5-fold. And as we've learned more about these risks over time, existing evidence-based prescribing guidelines have continued to lower cautionary MME thresholds from 200 to 120 to 100 to even lower. A majority of patients who have died from opioid overdoses had multiple sources of prescriptions and/or high dosages of opioids. In this graph, the gray sections of the bar represent those patients with fewer prescription sources and lower opioid dosages, while the blue sections represent greater than 3 prescriptions or high dosages of opioids over 100 MME. As you can see, only 6% of control patients had multiple prescription sources or high dosages, but a full 55% of those who had a fatal overdose met those criteria. A central premise leading to the proliferate use of prescription opioids was the argument that if they were used properly, they would not lead to addiction. But there's an increasing body of research that's debunking that myth, especially when we're talking about a high daily dose taken for greater than 90 days. Using data from a large medical claims database, this research group showed that patients on a long duration and high dose opioid prescription, defined as over 90 days at greater than 120 MME, they had a 122-fold increase in the likelihood of being diagnosed with an opioid use disorder. And I just want to pause to put that number into context. 122-fold. So the odds ratio for lung cancer in current smokers relative to non-smokers has been estimated at 40. And that's a well-understood, well-established medical relationship. And the odds ratio for heart disease in current smokers relative to non-smokers has been estimated at 2. And even at lower doses of 36 MME or lower, there was still a 15-fold increase. We're at a point where as many as 1 in 4 people taking long-term opioids for chronic pain in primary care settings struggles with opioid use disorder. Turning back to the graphs of the epidemic, the second wave of the opioid epidemic is heroin. Heroin is available in larger quantities, used by a larger number of people, and is causing an increasing number of overdose deaths. The heroin-related death rate, which is the orange line here, has increased 4-fold since 2010 through 2015. Nearly 13,000 Americans died from heroin in 2015. And the third wave in the opioid epidemic is fentanyl. Fentanyl is up to 100 times more potent than morphine and 50 times more potent than heroin. Its primary use is for managing acute pain or chronic pain associated with advanced cancer. It's extremely fast-acting. And although prescription fentanyl can be diverted for misuse or abuse, most cases of fentanyl-related morbidity and mortality have been linked to illicitly manufactured fentanyl when it's laced with heroin. The death rate for synthetic opioids excluding methadone has more than tripled over the past few years, and over 9,500 Americans died from synthetic opioids in 2015 alone. We are now at a point where in 2015, Americans lost 2.5 months of life expectancy due to opioids. This really underscores the seriousness of the opioid overdose epidemic, as we don't tend to see losses of this magnitude attributable to a single cause in the U.S. The last time was in 1993, attributed to HIV/AIDS. 2016 data wasn't available at the time that the analysis that I'm showing here was performed, but life expectancy in the U.S. has now decreased 2 years in a row because of opioids. The last time there was a 2-year decrease in the U.S. was more than half a century ago. So I'd like to transition to the CDC's response to the opioid overdose epidemic. At CDC, we have 5 priority areas to address this crisis, which complement the work of others across the federal government. They are to improve data quality and track trends to monitor the epidemic, strengthening state efforts by scaling up effective public health interventions, enhancing patient safety by supplying healthcare providers with data, tools, and guidance for evidence-based decision-making, empowering consumers to make safe choices, and coordinating with public safety and community-based partners to rapidly identify overdose deaths, reverse overdoses, link people to effective treatment, and to reduce the harms associated with illicit opioids. In September of 2015, CDC launched the Overdose Prevention in States Initiative to help state work, given that it's states that regulate health professions. They run prescription drug monitoring programs, or PDMPs. They're the ones administering large public insurance programs like Medicaid, and they have the public health surveillance capacity to track the epidemic. A total of 45 states plus Washington, D.C. are being funded via our Prevention for States, Data-Driven Prevention Initiative, and Enhanced State Opioid Overdose Surveillance Programs to support state-level resources to report non-fatal and fatal overdoses more quickly, identify risk factors for fatal overdoses, enhance PDMPs, sharing data to improve multi-state surveillance, among other strategies. To better equip healthcare providers with evidence-based guidance, in 2016, CDC finalized an opioid prescribing guideline for primary care providers to treat chronic pain outside of active cancer, palliative, and end-of-life care. A guideline was needed to better align opioid prescribing practices in primary care settings with the best available evidence to ensure safe, effective pain management, as research has shown that primary care providers prescribe the most opioids. The guideline's not a rule, it's not a regulation, it's not a law. The guideline's not intended to deny access to opioid pain medications as an option for pain management. It is intended to inform clinicians' discussions with patients and their prescribing decisions based upon the best available evidence about benefits and risks of opioid use. There's 12 recommendations in this guideline, including guidance recommending that opioids are not the first line of routine therapy for chronic pain, using caution when increasing dosages, especially more than 50 MME or MME per day, or to avoid or justify escalating a dosage to 90 or more MME per day. Not needing more opioids than needed for acute pain. 3 to 7 days is felt to typically be enough. Checking PDMPs for other prescriptions and to assess for high total dosages. Avoiding concurrent benzodiazepine and opioid use. And offering or arranging medication-assisted treatment for opioid use disorder. A lot of work went into making sure that we got this guideline right. But of course, the success of the guideline hinges on our ability to effectively disseminate that information and to get it out there into the hands of those who need it to move forward. And to that end, we've identified 4 priority areas to maximize uptake and use. This includes translation and communication, clinical training, health system implementation, and insurer and pharmacy benefit manager implementation. So I'm going to walk through this in a little bit more detail. On our translation and communication efforts, we've created this easy-to-follow checklist or algorithm about the CDC guideline, as well as a number of other fact sheets for both providers and patients, which can all be found on our website. We also released a mobile app for Android and Apple devices that includes prescribing guidance. It's based on our prescribing guideline. It has an MME calculator and motivational interviewing tips for prescribers when talking to patients about opioids and opioid-related risks. Within education and training, CDC partnered with the University of Washington to present a webinar series about the CDC guideline. 7 one-hour webinars are available for free online for CME. They can be accessible at the link at the bottom of the screen. And we just launched the 4th in a series of interactive online trainings for healthcare providers, shown here on the right. These trainings feature the recommendations in the guideline, providing sample scenarios, feedback, and resources, like conversation scripts for discussing opioid use with patients. This and all future trainings will be available for continuing education credit. Healthcare systems have the potential to improve pain management, including safer use of opioids through guideline-concordant care on a broad scale. To name a few activities to assist health systems in this area, we've created a clinical quality improvement technical package to help health systems develop processes and deploy strategies to facilitate adoption and use of the recommendations. This contains guidance such as identifying organizational champions, providing trainings on guideline communications, and mechanisms to provide auditing or feedback cycles to monitor progress. We also work to update clinical decision supports to integrate recommendations into electronic health records. So some examples of what might fall into that area are alerts when someone's about to prescribe something that might exceed a patient's MME threshold, defaults on prescribing amounts to when initiating opioids, prompts to check the PDMP. There's a few examples. We've also developed and piloted a coordinated care plan, providing primary care clinicians, practices, and health systems with a resource to implement structured and coordinated opioid therapy for patients with chronic pain. We're also working to better understand the effectiveness and the adverse effects of non-pharmacologic and non-invasive treatments for chronic pain. If we're saying that opioids should not be the first-line choice, then what should be? CDC is working with the Assistant Secretary for Planning and Evaluation in HHS and the Agency for Healthcare Research and Quality, or AHRQ, to support an evidence review of the literature. And this evidence review is focusing on the effectiveness and adverse effects of different non-pharmacologic, non-invasive therapies for five diagnoses: chronic low back pain, chronic neck pain, osteoarthritis, fibromyalgia, chronic headaches compared with non-opioid pharmacologic therapy, opioids, and other non-pharmacologic treatments. This review is in the final stages, and the report will be available to the public within the next few months. Private and public insurers and pharmacy benefit managers can also foster guideline implementation through improvement in coverage and service delivery payment models and proactive use of claims information. Some priority interventions that can facilitate guideline implementation include coverage for non-pharmacologic treatments like exercise therapy and cognitive behavioral therapy, removing barriers to prescribing non-opioid pain medication, reimbursing for pain management. We know that visits to discuss coordination for chronic pain treatment can be quite labor intensive. We support the coverage of patient counseling, coordination of care, and review of PDMP data. Promoting more judicious use of high dosages of opioids, including drug utilization review and prior authorizations, and increasing access to evidence-based treatments of opioid use disorder and eliminating barriers when it's available. And it's critical for insurers to implement payment models that improve access to interdisciplinary multimodal care. Has made it a priority to raise awareness about the risks of prescription opioid use, and last year released an evidence-based consumer-directed communications campaign to empower consumers with knowledge to help them make safe choices. The goals of this campaign are to increase awareness and knowledge among Americans about the risks of prescription opioids, and to increase the number of people who avoid non-medical or recreational use or medical use of opioids for pain management. CDC incorporated first-person stories into this public campaign, featuring individuals living in recovery, individuals recovering from opioid use disorder, and family members who have lost someone to prescription opioid overdose. I'll close here. Wanted to thank you again for the opportunity to speak today, and I look forward to your questions in the question and answer period.